Dear colleagues, welcome to our new webinar. It's a special month this month because it's the November month and we are fighting against prostate cancer. And for this special event, I have asked Alberto, Briganti and Declan Murphy to join me to do a debate pro and against the PSA screening. So let me introduce them to you if you don't know them already. So I have two fighters tonight. On the right corner, I have Declan Murphy, who is connecting from Australia. He's Associate Professor of Urology at the Peter MacCallum Cancer Center in Melbourne. And on the other side, on the other corner, I have Associate Professor Alberto Briganti from Italy, who is from Milan, Vita Salute San Rafael, and both of them are working in the field of prostate cancer. So this is a unique opportunity to have a debate. So first, we'll have Declan, who is going to express his position about the screening, and then you will have the opposite position from Alberto. And at the end, we will have a few minutes to discuss together the question you have raised or to feed the debate with the points we'd like to expand a little bit. Do not forget that during the webinar, you have the opportunity to vote or to have a question for either Declan or Alberto, but you need to pinpoint for whom your question has been raised. Otherwise, we do not know the target of your question. So please tell us expressively who you want me to ask a question to. And so the first speaker now is going to be Declan from Australia. Declan, thank you again for accepting this debate, and we are listening to you.
Good morning, Morgan. Good morning, Alberto. Good morning, friends. Well, I'm very pleased to be joining this debate from Melbourne, Australia. It's now 6 o'clock in the morning here. If you look out my window over the next few hours, you will see the sun coming up in this beautiful sunny country of ours. So my disclosure here is that, of course, as some of you know, I have written very many articles critical of the USPSTF recommendations. So I find myself in the unusual situation of arguing against my usually well-known position here. However, I think there are some interesting observations we can make about this USPSTF recommendation. Of course, we know this famous graph that is from Australia has been seen in every country around the world. The death rates from prostate cancer have reduced very considerably since PSA testing has come in. But what is unusual is that the incidence of prostate cancer was expected to increase. This is the trend we expect to see because the population is aging. But we have a problem here because the incidence excuse me, is not increasing. What we see here is the incidence as was expected to rise, but what has actually happened in the past 4 or 5 years is the incidence has dropped very significantly. This is data from Australia, but we have seen the same data in many Western countries. So what has happened here? Well, what has happened is that there has been a lot of negative publicity about the early detection of prostate cancer, really quite consistently over the past 6 years since the PLCO data came out. I think PLCO has been the main problem, and this negative messaging about early detection has led to decreased PSA testing and therefore decreased incidence. And this is the problem. This is the reason why I think USPSTF took action and why they have a point. If we consider that the strategy of screening for prostate cancer using PSA test and rectal examination leads to these two issues, over-detection and over-treatment, we all accept that this is harmful, which is why population-based screening is not recommended. So let's think about the USPSTF, and if you have no idea who these people are, let me summarize it for you. This is a US government appointed body. They're an independent panel of experts in prevention and evidence-based medicine. They make recommendations about screening in particular, so it's a preventive medicine group, and they really are aiming at primary care physicians, general practitioners, and their recommendations are based on people who have no symptoms. So this is really about screening interventions, and they have made a number of recommendations over the years about breast cancer screening, colon cancer screening, etc. And it's interesting to note that the composition of this panel includes the list of specialists and generalists you see here. However, there are no urologists and no oncologists of any type on the panel. This is quite a deliberate strategy from their point of view, but we might argue it limits their expertise in this area. The USPSTF issue a number of grades depending on the strength of the data and their recommendation. And what I want to draw your attention to is the grade D recommendation you see highlighted here, which means the USPSTF completely recommends against this service because it's much more likely to cause harm than any benefit. So what did they say about PSA testing? Why are we discussing this? Well, this is their very famous recommendation which they issued during 2012. They came straight out with a grade D recommendation and basically said nobody should ever have a PSA test. So regardless of race, regardless of risk factors, nobody should ever have a PSA test. And of course this caused a lot of reaction from us as urologists. We all wrote many papers and blogs reacting to this. And it was very effective. The Australian general practitioners, to give you some idea, reacted by saying they likewise in their preventive book do not recommend against PSA in favor of PSA testing. And they even write that even if there was a benefit, you have to very carefully draw attention to the harms of all this treatment. So don't even mention it, don't bring it up. And of course what we know is that the population is living longer. Prostate cancer gets common as we live longer. So these cancers will still be out there. And I'm sure Alberto is going to show lots of nice data about this. So I'll preempt him by showing one of the nice papers that has shown the effect of the USPSTF, because we've had this in place for a few years now, 3 or 4 years, so we can now begin to see has there been an impact. And even in Canada, where USPSTF is not officially endorsed, we see that when this group looked at the impact, they saw that when USPSTF happened here, the number of biopsies dramatically decreased. And also, not just the number of low-risk cancers, but the number of higher-grade cancers also decreased. So quite a worrying trend. And they speculated that the reason the number of biopsies had decreased was because there were less patients coming in with a raised PSA test. And they directly linked this to the recommendation of the USPSTF, which seems to have spread beyond North America, where it should have its most effect. Similarly, in the US, this paper from David Penson's group again showed the impact here of the preliminary recommendation, because the preliminary recommendation came out a few months before the final one, and we see really a quite dramatic decrease in the number of prostate cancer diagnosis, and colon cancer is shown here along the same time point to show that there was something specific to prostate cancer happened around that time. And I think it's fair to say, and I'm arguing the other point for a moment, that underdiagnosis may now be a significant concern. We started out saying overdiagnosis was a significant concern, but now it's probably swung the other way. We're probably going to miss some cancers. So we've just published a paper from Australia showing the impact of USPSTF down here, 20,000 kilometers from Washington. And what we show is that over the past 5 years, and these are different states within Australia, the incidence of prostate, numbers of PSA tests being ordered has dropped dramatically, down about 30% since this recommendation came in. And of course, less PSA testing means less prostate biopsies. They're all falling off in all the states in Australia. And this has also led to less radical prostatectomies. But, you know, I may argue this is a good thing. I think we have been doing too many radical prostatectomies in certainly the USA over the years. And I think the message is now actually finally beginning to sink in. This data, myself and Stacey Loeb wrote about in Nature Urology recently based on a Matt Cooperberg paper, shows that of the low-risk patients in the US, and this is temporal, this is over the years, you can see that the use of active surveillance has finally begun to increase. So the blue bars here are active surveillance, so no change over the years. And now finally in the past 3 or 4 years we see the proportion of patients with low-risk cancer in the US finally beginning to increase. Similarly, we see the proportion of patients with intermediate and high-risk cancer more likely to have surgery rather than watchful waiting or radiation therapy. So some good things. I think we are beginning to see at least the over-treatment effect being addressed in the USA. So therefore you might ask, how could the USPSTF recommendation possibly be a good thing? How can I argue this point that it's a good thing? And I think it's summarized on this slide here, and these are some books and blog sites that exist in the USA, and these are very, very powerful influencers. And I think that it's fair to say, especially in the US, that the over-treatment that has been pervasive has clearly damaged the early detection lobby. The lack of active surveillance in the US in particular, I think, is what drove the USPSTF to say, guys, you've got to stop all these radical prostatectomies, too much erectile dysfunction, etc., too much cost associated. And I think that we therefore have had this call to arms to say we've created this problem ourselves by having too much overtreatment in the US, which is where this recommendation came from. And only in the past few years, since this debate has started following PLCO, we've begun to see active surveillance finally being embraced to some extent in the USA. Now, I want to here, of course, draw attention to Donald Trump, because I think, of course, nobody has failed to notice that the US have just voted in this rather strange character as their president. And he went in on the lobby, on the claim that he was going to make America great again, I think, which is clearly resonated with voters in the USA. So I think we can make the argument post-USPSTF that we should make PSA great again. And I'm now campaigning on this lobby that we need to make PSA great again in the post-USPSTF protocol. So the big shock we've had to the European system with our UK friends deciding to vote out of Europe has had reverberations all around Europe, all around the world, really. And I think with USPSTF, we've had a Brexit-type moment where it's been such a shock to our system, no more PSA testing, that we've had to recoup and rebuild from the ground. And I argue, like Donald Trump, that this is our opportunity. I think we need to make PSA great again. We need to screen smarter, and we need to embrace active surveillance so we therefore reduce overtreatment. And I think that unless we do these things in the US, then we're going to be up against this negative recommendation for many more years to come. And of course, a lot has changed over the years. In the run-up to PLCO and the USPC, this was the way we did early detection of prostate cancer. No significant counseling, no risk calculators, etc., and really quite basic biopsy techniques. And you'll see here, of course, that the approach to early detection of prostate cancer is now a much more sophisticated paradigm, and we have much better tools to select our patients. So finally, how do we make sense of all this? Well, post-USPSTF, we released this Melbourne Consensus Statement on the early detection of prostate cancer based off the back of the Prostate Cancer World Congress that we had convened, many experts from around the world, including the US. And all of this was quite well received, actually, because it was in an era, 2013 and 14, post-USPSTF, when there was a lot of confusion, and our argument was that we wanted to get rid of the confusion. And here's what we see, these 5 simple statements, which I'm sure some of you are familiar with, and I think this is a good reaction to how we do early detection. So in conclusion, Chairman and friends and Alberto, I think although this recommendation is wrong in many ways, it has forced us to consider how we approach early detection, and I think that's a good thing. The message about overtreatment is now finally being heard in the USA. We've always known about it in Europe and Australia, and maybe if we do adjust our behaviors, we will be able to have a more favorable recommendation. And in the meantime, I think we need to make PSA great again. Thank you.
Thank you, Declan. Thank you very much for your good points. And I think that Alberto Briganti is going to play the lawyer of the devil. So we have another vision of the PSA screening, and I think we need to go through his presentation, and then I will raise a few points.
So I'm still in the office. I would like to thank Morgan, the organizing, for allowing me to stay a little more in the office to actually show you some of the data and some of the arguments against the recommendations against the use of PSA for screening. So many of the data have been already showed by Declan, who actually anyway made a great presentation against the recommendations. So thank you very much for helping over. But I will just try to give you my view on why recommendations are wrong. And Declan has already showed you these slides, which actually is a summary of the recommendation from the US Preventive Service Task Force, which recommends with a grade D against the use of screening PSA based for prostate cancer. So the D grade, you see summarized again in this slide, is something that summarize the fact that the task force consider use of PSA of no use, so discourage the use of PSA for screening. And this is mainly based on two things. One is the no benefit for screening on prostate cancer death in the PLCO study. And the second issue and the second reason is the overdiagnosis related with screening with regards to prostate cancer. So I will just try to address these two issues in my presentation. So understanding why I am against the recommendation is certainly starting from understanding the design of the PLCO trial. I'm not showing any fancy slide on Trump or other politicians. I'm just showing some data which you should know to understand better the biases and the significant limitations of this trial. So this trial has been the first one together with the USPSTF to be published on New England Journal of Medicine in 2009, the same issue of the USPSTF, so they were published together in the same journal in the same month. And this study was actually a great study that randomized 76,000 patients to annual screening for usual care as the control group. And men in the screening group were offered annual PSA testing for 6 years and DRE for 4 years, with a cutoff of PSA for in terms of value to determine whether patients were suitable or candidate for prostate biopsy. Now, the main results of this study are summarized in these slides. I think that many of you who are online already know these results, but I think we should reiterate a bit what are the limitations of this trial. There was a significant increase, which was statistically significant, in detection rate of prostate cancer in those randomized to PSA screening as compared to the control group. But as you can see in the right part of these slides, there was actually no benefit in terms of prostate cancer death between the group randomized to PSA versus those randomized just to observation. Now, observation is not the wrong term from this study, because actually these patients randomized to the control group, and I will go there in a minute, were not randomized to observation, but were just randomized to less intense screening. So the main limitation of this study, which prompted which was one of the main reasons for the recommendation against PSA testing, is the main limitation is certainly contamination. So let's go into detail. You see here patients were screened annually with PSA for 6 years, but then you see one thing which is a little bit worrying. 44% of patients prior to initiations of the trial had already PSA tested. And more importantly, more than 50% of these control patients underwent screening, in the sense that underwent at least one PSA testing over the study period. There was a compliance with screening in the screening group, in the screening arm, that was 85%. But look at here, 32% compliance with biopsy within 1 year, and the follow-up was 13 years. So let's see what is the difference between this study and the study which is much more robust in terms of methodology, which is the USPSTF way more patients randomized, screening done with PSA every 2 or 4 years, depending on the center and depending on the nation. The biopsy was done in case of ERE positive, PSA-3, but look at the contamination rate. That was 20%. That means that in the control group, only 20% versus 52% of patients received anytime any form of PSA testing. Compliance with screening was high, but compliance with biopsy was also very high, 80–90%. The follow-up was pretty much the same in the updated results of both trials. But this is more scary. So recently it has been shown by this nice letter to the editor that was published on the New England Journal of Medicine that reassessed the rate of PSA testing in the control group. That was done using the health status questionnaire that was also originally used, but that was re-evaluated in a subset of patients. And this subset of patients, we found that more than 80%, not 50%, more than 80% of the participants in the control group without baseline screening contamination, they did report to have undergone at least one PSA test during the trial. 50% of them reported PSA tested in the past year, 70% of them reported to have PSA tested in the previous 2 years. And that was the control group that was supposed to be randomized to no PSA at all. But more importantly, again, the same study showed that the cumulative number of PSA tested that was done in the control group was higher when compared to the number of cumulative PSAs done in those randomized to PSA. So the contamination here is a significant bias. And you also can summarize and see an overview of this contamination if you look at number and the incidence of cancers in the control group of the PLCO versus in the screening group of the USPC. So the number of cancers detected in the control group of the PLCO was pretty much the same as the number of the cancer detected in a real screening trial, which was the USPC. So pretty much the PLCO, we can interpret this trial as a trial which tested screening versus less intense screening. 44% of men were pre-screened. Well, one may argue that the follow-up was not that long since some of these patients, they do have a long life expectancy. There was a number of deaths that was very low, less than 0.4%. So few events, 52% contamination among controls, which was as high as 80% in the reassessment that was recently published. 15% of patients was not compliant in the screening arm, and there was poor compliance with biopsy. Now, this was the story of the PLCO. That was the main reason why the U.S. Presenting Task Force reported this statement against screening. Now, let's see what happens if screening is done in a more robust way, in a less contamination rate in the control group. This is the USPC trial, which, as you know, has been updated several times over time. And you see one thing, which is a strong message from the screening trials, that the more time you wait and the longer time of observation patients have, the higher benefit of screening can be weighted and can be observed. So, and in these updated results of Dr. Sheridan and colleagues with a follow-up of 13 years, there was a 29% of relative risk reduction once you account for contamination rates in favor of patients randomized to screening. The number needed to screen, which is one of the weakness points of the old story, went down to 781, and the number needed to treat went down as to 27, just waiting more time and just seeing patients at longer follow-up. Now, these numbers are even more favorable. If you look at some sub-cohort of the USPC, the Göteborg screening trial that started at standalone RCT, that was later incorporated into the USPC. You see here that the number needed to screen went down to 293, with a number needed to treat that was as low as 12. This is the number needed to treat to save one death from prostate cancer. So you see the numbers. And these numbers, if you wait more, they are expected to go even down, more down in terms of number needed to screen and number needed to treat. Now, the possible reasons for better benefit of the USPC and in particular of the Göteborg trial for patients for men randomized to screening is that there was a longer follow-up. In the USPC and especially in the Göteborg screening trial, patients were younger. There was a lower PSA threshold for biopsy. That was in other USPC and in the PSCO. There was also a shorter interval of screening every 2 years than in the other USPC sites. But more importantly, the number and the rate of contamination was absolutely lower, and actually also the adherence to biopsy when was prescribed was absolutely higher. And how does this compare with other cancers when screening is usually done? Well, I would say very favorably. You say in these slides that the breast cancer, you just pick up those women with an age of 60 to 69, the number needed to screen is even higher than what reported in the trial of the Göteborg part of the USPC. The number needed to treat is 10. So it's pretty much the same as prostate cancer when you apply the correct methodology and you wait long enough to see the benefit of screening. One thing which has always sometimes not always and not well assessed is how much screen should be intense. And this is a nice study that was done in the court of the Finnish court of the USPC here. You see here, if you do PSA very frequently every year, in this population of patients, regardless of age of screening initiation, you see that there is a benefit in terms of reduction in prostate cancer mortality. So that is not in favor of yearly screening with PSA. This is just a model that was derived by the Finnish part of the USPC. But the bottom line here is that if you do more intense screening, you may have even more benefit. And this is again in favor of prostate cancer screening with PSA. Then what happened in the US after the recommendation that was done by the US Preventive Task Force? Declan has already showed some of these data. I'm just updating you with additional data. Not unexpectedly, the number of distant stage disease and the number of locally advanced prostate cancer patients have increased over time. And this, again, a strong argument in favor of that, decreasing the number of patients exposed to screening, which actually was also reported in the same results in the same study period, increased the number of men that was in the same period, again, diagnosed with locally advanced or even metastatic prostate cancer. And honestly, I think that many of you online as practicing urology are also experiencing this. You see more and more patients with local advanced disease coming to your office for a second or first urological consultation. But luckily enough, the things are kind of changing in a good thing. This is a study which is not published yet. My friend Firas Abdullah from the States gave me these slides. You see here, as after the 2012, when the recommendation was released, you see a drop in the screening. So a drop in the use of PSA. But then at some point in time, there was a plateau. So it seems that the PSA screening rate that at some point in time went down, now is stable. So it's not going down anymore. So in a way, urologists in the US are realizing that PSA is useful and are still using it as a good biomarker to discover prostate cancer. So this is a good story about what is the future of screening. Well, I do believe and I do agree with Declan that screening may be not useful and it should not be done for every man. We should use PSA intelligently. We should start with PSA at younger age and then eventually individualize subsequent testing. We should always consider something which is patient life expectancy and of course not overexpose elderly patients to PSA. I do believe that in the future PSA will not be a standalone screening test but should be incorporated also in patient risk stratification tool with the aim of minimize overtreatment. So one thing which has been kind of proposed as a compromise to not to overexpose people to screening is, as the EU guidelines suggest, to use PSA at a young age and then to individualize screening programs according to the PSA level at the age of 40. This can be done according to the Malvo Preventive Project, also in patients in their 60s. So patients who do have a certain PSA above a certain threshold, whether they are testing in the 40s or in the 60s, they are those who can be considered more candidate for intense screening, while the others actually can be just followed with less intense PSA testing. And this is what reported by our guidelines, which are the EU guidelines. So this sort of risk-adapted strategy is what is suggested by the EU guidelines. But I have to acknowledge one thing, that this kind of PSA-based adapted strategy according to PSA at young age is based on retrospective series. It has never been prospectively validated, and this is what we have to do in the future. So thank you very much for your attention, and look forward to discussing with you.
Thank you, Alberto. It was very clear, and we received, meanwhile, you were speaking many comments from the audience, and I would like to emphasize the fact that we started from with 80 people, and now we are more than 120 people connected. So people are really interested in your arguments, both from Declan and Alberto. The point is that you both discussed the same topic, and you had very convincing data to bring up to the audience. I would like to raise first one point, and we did not discuss, because when we are in Italy, in Australia, in France, we are discussing with our national authorities, I would say. And finally, the debate is more or less the same from a country to another. One question that we did not treat is the cost. And behind screening, there is a cost, because the prostate cancer screening is not relying only on PSA. When you look at colorectal cancer or lung cancer, they are perfect, I would say, tests. And everyone is acknowledging the fact that the PSA is not the unique test. And when you do, you, Declan, or you, Alberto, on a daily basis consultation, and when you advocate screening in a one single case, not on a broad scale, when you discuss with the patient, you know you have something in your mind that is not going only to be a blood test, because the blood test is the entrance to the screening. So what would be the cost on a very large scale, and what would you consider today in your daily practice as very useful according to your practice to, in addition with PSA, what do you include in screening today? Targeted biopsy, MRI, PSA, or is it just PSA, and then you will see what you do? Or do you have a systematic behavior? Please, Declan first, and then Alberto.
Thank you, Morgan, and congratulations, Alberto, for your very nice presentation, which, of course, I agree with everything you say. So the point of putting up this topic is to spark the discussion, and the questions Morgan asks are very important. So I think starting with PSA is a very important point, and of course with the individual patient. So of course we have many tools like MRI and sophisticated biopsy techniques, biomarkers, etc. we could use, which adds cost, which is a concern. But we can start very simply by assessing the individual patient risk, and we have risk calculators that help us clarify this. And then based around, as Alberto showed at the end, the PSA at the patient's age at an early point of screening, for me, in our practice, is very important. So we are very keen on the baseline PSA testing for men in their late 40s, early 50s, and not the absolute level, but the relationship of the PSA to the median for the patient's age, I think, is a very simple way of helping plan the future. So for me personally, when I turned 40 years of age, I decided to do a PSA test. I was very far below the median. So do I have an annual PSA? No. I'll have one again maybe this year. I'm 45 years of age. And I think this, thank you, of course. And this idea that we can risk stratify around the patient's age and the baseline PSA should be reassuring to those people worried about expense. And Andrew Vickers before, after the BMJ paper, proposed maybe 3 PSAs in a lifetime might be enough for many patients. So PSA around 50, one around 60, etc. And although the screening population intervals required do require frequent PSA tests, that was before we knew about baseline PSA, PSA around the median, etc. And we know we can't argue the case for population-based screening for everybody on a regular basis, but we can use PSA smarter, as Alberto says, And I think baseline PSA testing is a simple and cheap way to do it, actually.
Alberto?
Yes, I completely agree with what Declan said in the sense that I think that we should, and I like the slides by Declan, we should make the PSA strong as it used to be in the past, in the sense that we just have to use it in a better way. So I agree with the policy of using PSA at young age as a starting point to actually then decide in a risk-adapted strategies when and how to screen again these patients, to test again these patients. There are other biomarkers that are now being tested, for example, 4K score and others, which may be used in the beginning to substratify patients according to the initial PSA. So what eventually we'll need to improve is not only to have a baseline PSA to understand which patients should be tested more frequently or not, but also to complement PSA with other parameters. And I agree again with Declan that we do have parameters already available, like multivariable risk calculator. The indication for further assessment in patient prostate cancer cannot be based by PSA alone. Should be a multivariable, multitasking approach.
Okay, I have a few questions coming from the virtual audience that we have. So there is a question coming from Fernando Gomez, and then it's going to you, Alberto. What is the role in your practice of, and what is your opinion of is there a remnant role for digital rectal examination finally today? What is your opinion? Just briefly.
Well, as all urologists do, I always do DRE in my current practice. We all know that the sensitivity of DRE is quite low, but it can be complemented together with PSA in patient assessment. So I don't disregard the importance of DRE in my clinical practice.
In addition, it creates a link with the patient. You feel proximity with the patient, with the DRE. So it's important to create a link. There is a question to Declan from Monique Rubul. She's asking, and Declan, are you not afraid of more overdiagnosis if you start testing at very young age? Will men comply with, in your opinion, an interval between two tests of 5 up to 10 years interval? So there are two questions within one. Are you not afraid of more overdiagnosis with starting too very young? And in addition, what about I would say the lag between the two tests?
So that's and this question from Monique Rubal, world-leading expert in this area. She's right, of course, to be concerned.
She's online.
Yeah, hello, Monique. So it's very important that if we recommend baseline testing and then we plan future testing based on the baseline risk, that we adhere to that. And she's right, because critics of this approach will say, if you do a PSA test for a man aged 45, he will have a test every single year for the rest of his life, and that will be inefficient. And that's because in general practice, sometimes it's more convenient and you forget, is it 3 years or 5 years? And she's right to be concerned that if we advocate for early testing, and my view is that may allow us to do less frequent testing. In real life, it sometimes turns into more frequent testing. But the second question about the overtreatment, are we concerned about overtreatment? No, because as we wrote, and Monique is a co-author on the Melbourne statement, we have to separate diagnosis from treatment. So just because we diagnose a lot of men, and we still have to diagnose a lot of men to screen out the more aggressive cancers, does not mean that we treat all these men, and that's where we use active surveillance. So our reaction to overdiagnosis, which we accept is still an issue, is to reduce overtreatment by having a much more risk stratified approach to how we manage those cancers we diagnose. So I think overtreatment is something we can deal with regardless, because we do embrace active surveillance.
Okay. We try to be brief because there are a few points coming from the audience, and I would like to emphasize as much as I can. There is a question for Lorenzo Duto. There is a question for Prof. Murphy asking, as the risk assessment tools have been developed on screen patient cohorts, can you confidently recommend their use on the assumption that their predictive power will remain unchanged for single patients?
Sorry, I missed the second half of the question, Morgan.
Just Lorenzo Duto asked you that based on the fact that the risk assessment tools have been developed on screen patient cohorts,
Yeah.
Can you confidently recommend on a single man basis diagnosis the predictive power? Are you confident in that tools?
It's a really good point Lorenzo makes, and of course it's even more so when you're outside those screened populations. So that best data is predominantly from the ERSPC populations that Monique's done all this work on. So how do you then sit in Australia or Russia and take that same information and apply it to the patient in front of you? And it's always a limitation of these large data sets. And what I say to patients is, I always make that point that the limitation here is this is not necessarily meant from our region here, but in Australia, almost all our cancers are European lineage. It's the European descendants in Australia who tend to get the highest incidence of prostate cancer. For that reason, I think we can extrapolate from that within the limitations. But he makes a good point, which applies to all risk calculators, actually.
Okay. One last question, if you don't mind. So there is this question coming from Evaldas Graboskas to Alberto, for instance. So what do you do in daily practice if there is this man, age of 70 years old, 78, is coming out of screening to your office with his own personal made PSA? What do I have to do? Do I have to biopsy? How do you manage these guys? Because in fact, they have been doing screening on their own, I would say. And so do you tell them, well, you don't have to care about your PSA, or do you go further?
No, I think we should put a little more clarity in this, because there are several considerations that need to be done while considering a patient's candidate for further assessment. We need to look at several things: patient life expectancy, patient comorbidity profile. We should look of multivariable assessment of patients, not PSA alone, because several studies, and it's not a matter of study. Every one of us as urologists know the PSA alone cannot drive the entire patient's evaluations in the initial phase of potential early diagnosis of prostate cancer. It's not only PSA. It's a multivariable risk assessment. And if you take these calculator whatsoever, can you call them nomograms, calculators, you need to externally validate them before applying them to all populations. And many of these nomograms and risk calculators have been already externally validated in non-screened population as well.
Okay. One last question, if you don't mind, to Declan. There is this question from the colleague from UK. It's outside Europe. It's, dear Mr. Murphy, what % of the patients with prostate cancer has a low PSA, in fact? Could those patients have indeed a high-grade prostate cancer? It's coming from Vitaly Mezentsev, a urologist from Essex in Princess Alexandra Hospital. So what is the proportion of patients with prostate cancer with a low PSA, in your opinion?
Well, it's a very small population, Vitaly, as you know, but it's an important population, because we know that these men, and that's why the digital rectal exam is still got some value. Those men who do present with prostate cancer with a low secreting PSA are sometimes very aggressive. It's sometimes a neuroendocrine differentiated tumor as a primary, and that they're important. And this matters because here in Australia we have had a recent recommendation against the use of DRE in the screening population, which I disagree with, but it has come into one of the recommendation guidelines here in Australia. So I think we should offer DRE in addition to PSA. But having said that, we know from ERSPC that initially, I think, Alberto, the DRE was not mandatory for the ERSPC inclusion. So if a DRE is going to put a man off from having screening, I will always recommend that, look, just have a PSA test. That adds a lot of the value that's out there. Morgan, I know Stacey Loeb from New York has been tweeting about the webinar, so it's wonderful to have Stacey tuned in from the USA as well.
Yeah. And so Stacey is there, but she didn't raise the question through the webinar. And there is one last point I would like to emphasize, and then we will close the debate for now on, is to Alberto. It's coming from Nikolaos Liakos. He's asking you, Professor Briganti, which screening tests will be the successor of the PSA screening according to you? Is it going to be Phi, 4K, or PSMA expression? What do you think about these three? If you
honestly, my personal opinion is that if we still use PSA in a smart way, PSA remains unbeatable.
Okay, that's a clear point.
That's my personal perspective.
So I think it is time to close this discussion, but we can keep moving forward on Twitter and Facebook and all the social media. We'll be happy to follow on that discussion in the next EAU Congress also in London. And for those who are available, it's still time to register to the EMU Congress in Milan this week at the end of the week. So thank you, Alberto Briganti, for being there tonight so late. Thank you for being with us, Declan, so early in the morning. I was very happy to have the opportunity to reach you on the web. And we'd like to also, on behalf of the three of us, to thank Ton Brothers from the office of the EAU who did a great job supporting this webinar and developing all the technical aspects. Have a great evening or a great day if you are in Australia, and do not forget to support the movement. Thank you very much and see you soon on the web. Bye-bye.